Hello, everyone. Welcome to our Zoom meeting. Today, we're going to have different topics that we can discuss. Dr. Mustafa and his team will be presenting. So when you have a minute, I'm going to hand it over to you, Dr. Mustafa. Thank you so much for arranging this and preparing the talks. Thank you.
Thank you so much, Dr. Nader. Hello, everyone. Thank you all for joining us today. So let's go on ahead and get started. We have a great session ahead, starting by SYNCOPE in older adults, presented by Dr. Shroog, Dr. Tibyan, and Dr. Hashim.
Hello, everyone. Thank you, Dr. Mustafa. So, good morning, everyone. Good afternoon and good evening, wherever you are in the world. My name is Shroog, and I'm internal medicine trainee in Ireland, and I'm proud to be a member of Yellow Team. And it's my pleasure to welcome you all today. I would like to take the chance to sincerely thank Dr. Nader for this incredible opportunity. And thank you for my amazing team for this dedication and hard work to make this presentation possible. I'm going to share my screen now. Okay. Is everyone hearing me, just to make sure that my mic works?
I can hear you clearly.
Yeah.
And the screen?
Yeah, it's visible.
Okay. So my presentation today is about syncope, and I'm going to present it with Dr. Tibyan and Dr. Hashim. Our objective today is to be able to describe the factors that may lead to syncope in older adults, to describe the elements of evaluation, history, physical examination, testing of adults with the syncope, and treatment option for syncopes. So the topics would be covered: natural history diagnosis, pathophysiology, evaluation including history, physical examination, diagnostic testing, treatment, prognosis, public reporting, and choosing wisely recommendations. As introduction, we have first to know that what the definition of syncope. So syncope is a symptom complex composed of sudden and transient loss of consciousness resulting from temporary interruption of global cerebral perfusion. And the rationale behind choosing this topic is actually it's a common reason for attending an outpatient clinic and emergency departments and hospital admission. Annually, it accounts for approximately 1 to 3% of emergency department visit and 2 to 6% of the general hospital admission. The incidence rate of syncope increases with age, as it doubles for those above 70s, and for those above 80s, almost 3 to 4 times in comparison to syncope happens among the younger people. So approximately 80% of the patients hospitalized for syncope are above 65. Potential causes range from those that are benign and self-limiting to those that are life-threatening. In older adults, the cause of syncope can often be multifactorial, adding to the diagnostic difficulties. Now we have two graphs. The left graph represents the survival rate of syncope in comparison to the general population. So the general population, or the control group, the people with no syncope, represented by the black line. And the red line actually shows that the population, the survival rate in population with syncope secondary to cardiac cause, as we see that the less survival rate, or the least survival rate among those people, is between those who have syncope secondary to cardiac disease, which means more mortality, in comparison to those who has syncope secondary to vasovagal attacks. And it's almost the same as general population. The blue line represents that the people who had syncope secondary to neurological cause, and the green line, this is unknown cause. Syncope is unknown cause. Moving to the right side, to the right graph, is actually represent the incidence rate of syncope in comparison age. So as we see that, as we mentioned before, as long as the age getting older, simultaneously the incidence rate of syncope increase, and almost 3 to 4 times in those who are above 80s. Let's warm up with the case scenario. And this patient is actually one of the patients admitted with us last week in the hospital. He's 21-year-old, healthy and fit male with free medical background, attended emergency department with a seated syncope while he was having his breakfast. His syncope witnessed by his father, and he described the syncope as transient loss of consciousness, lasted from 5 to 10 seconds. The patient fell on the floor. He was completely flat, and there is no any jerky movement or incontinence. And then he regained his consciousness without any confusion after that. He is non-smoker, and he drinks occasionally, and there is no illicit drug use. He has no family history as well of cardiac disease or seizure or sudden death. On his evaluation, he was vitally stable, no postural drop, and line standing blood pressure measure, and his blood sugar was within normal range. Examination, chest, cardiovascular, abdomen, and CNS all were within normal. All were normal. So when we did his ECG, it was normal sinus rhythm, CT brain was normal, and chest X-ray, no change as well, it was normal. His laboratory tests, including full blood count, urea and electrolytes, including magnesium, calcium, LFTs, serum troponin, D-dimer, all were normal. So the question for the floor, would you admit this patient and why? Hello?
Yes, I think this patient is for admission.
And why do you think it's for admission?
He's a young patient, and we need more. We need to observe him and evaluate for the underlying cause of his syncope.
Will I go with you? It's actually a tricky case because usually young people with no background or any comorbidities usually it's a green flag actually. But seated syncope is actually could indicate a cardiac cause. But the other thing, he was eating at that time, so it could be, situational as well. But anyway, it was to investigate. So what would you do next if you admit this patient as inpatient?
Echocardiogram.
Excellent, and we did that. It was normal. But the fastest thing, so usually echo, if we book the echo for a patient, it takes maybe 2 to 3 days to get it done. What else could be done faster than that?
I think we will ask for telemetry as well.
Yes, telemetry is next. So that's what we've done, or the on-call team actually did overnight. And at 8 morning, CCU nurse rang about his telemetry, and that was the result. Let me show you. This is his telemetry. It's actually showed a pulse of 7 seconds. And at the same time, when the nurse checked the patient, he stated that he had pre-syncope. So it was a cardiac cause. So let's discuss the causes of syncope. Reduced cardiac output because it caused brain hypoperfusion. We have rhythm disturbance, one of the causes of cardiac cause, tachyarrhythmia, such as ventricular tachycardia, bradyarrhythmias, blocks, chronotropic incompetence, and structural heart disease, such as aortic stenosis, hypertrophic cardiomyopathy, chronic artery disease, and that's why we need to do echo. And we've done it for that patient, by the way, it was normal. Reduce intravascular volume if someone had bleeding, dehydration if someone has gastroenteritis, for instance, pulmonary causes such as massive pulmonary embolism. They can present with syncope. Altered peripheral vascular resistance, functional or structural. So for the functional, we have vasovagal. It represents 21 to 31% of the cases. And this is actually those who have like a kind of, like those who express an intense emotions. For people, like some people who see blood for the first time, they just get collapse. Or those who express an intense pain, they can get collapse. Other causes such as carotid sinus syndrome, and most of them because of the carotid sinus hypersensitivity. Situational syncopes that include swallowing, micturition, defecation, postprandial hypotension, and the structural autonomic insufficiency that include primary conditions such as pure autonomic failure, multiple system atrophy, Parkinson's disease, and the other secondary conditions such as diabetes and spinal cord region or uremia. Drug causing reduce cardiac output or alter peripheral resistance. So some degree of orthostatic or postprandial hypotension, whether related to reduced intravascular volume, altered peripheral resistance, autonomic dysfunction, or medication use, may contribute to syncope in 48 to 84% of older patients. Most of the patients, like admitted in the hospital, are geriatric patients. So always, when the patient came with a syncope, we have to review their medication because most of the patient they have comorbidities and hypertension represent like the most one of the common comorbidity. So you can just manipulate their medication or stop the antihypertensive or even some of the antidepressant that has an anticholinergic effect, such as tricyclic antidepressants. Now, let's go to the natural history of syncope. As we defined syncope before, that is hypoperfusion to the brain. And as we know that cerebral perfusion pressure is equal mean arterial pressure minus intracranial pressure. And we need from 60 to 160 millimeter mercury to get that achieved. So any drop in the cardiac output or vascular resistance, which both of them contribute to the mean arterial pressure, can lead to decrease in systemic blood pressure and reduce cerebral perfusion, and all they can lead to syncope. Now let's see the effect of aging. Reflex mechanism are less responsive with aging. So what do I mean by reflex? If we stood all of a sudden from sitting or lying position, the gravity makes our blood pressure drops. So how our body interact to keep our mean arterial pressure. So it increased the cardiac output, and that would be through increasing the heart rate. This mechanism specifically, it decreased in the elderly. So let's go back to the point. They mentioned that decreased ability to increase heart rate in response to sympathetic stimulation, and they have increased sensitivity to effect of dehydration, diuretic, and vasodilator medications. Comorbidities that affect postural response are common, such as diabetes and Parkinson's disease. Medication may further impair postural reflex. So vasodilator, calcium channel blocker, and beta blocker, ACE inhibitor, tricyclic antidepressant, all they can make these reflexes impaired because they act through the same specific stimulation. But if we have a receptor that blocked by medication, it do no effect. Now, pathophysiology is addressing the cause and mechanism to prevent syncope. The integrity of a number of control mechanisms is crucial for maintaining adequate perfusion of the brain and cerebral oxygen delivery after a sudden change in blood pressure. So carotid and aortic baroreceptors, one of them, sympathetic renal stimulation of renin angiotensin system, and arteriolar autoregulation. Age-related decline in adaptive reflex, as we mentioned in the previous slide, comorbid conditions and medication can all have a role in older adults presenting with syncope. Address these issues by increased caution with postural change, physical counter-pressure maneuvers such as leg crossing, and compression stocking to increase the venous return. Adequate hydration, simplification of the patient medication regimen to eliminate excessive medication. Now we have to know that epileptic seizure is a common cause and differential of transient loss of consciousness, but it's no longer categorized as the cause of syncope, as we know that the pathophysiology of the seizure and the syncope are different. Syncope is hypoperfusion, and the seizure is extraelectrical activities from the brain. It's important to differentiate a seizure from syncope as a cause of transient loss of consciousness. Now we have this table. It actually tells us a difference between the seizures and the two types of syncope, the cardiac and vasovagal. So as we see that, it tells us the difference before the incident itself, during the incident, and after the incident. So before the incident, it can happen in any position in the seizure and the cardiac arrhythmia, but in the vasovagal, usually related if someone stand upright for a long time. Regarding the warning symptoms, it's written here none for the seizure, but some of the seizure, as we know that it could be preceded by aura, so it can happen for all of them. And the palpitation, usually associated with the syncope secondary to arrhythmia. Nausea and visual changes happens or most common between people who have syncope secondary to vasovagal. During the incident itself, incontinence, oral frothing usually happens with seizures, and then pulse usually absent in the cardiac syncope. And the tone, they said here, the tone is rigid with the seizure and flaccid in arrhythmia and vasovagal, but we know that some seizures can be absent seizure. The patient can be flat as well. And after the incident, nausea and diaphoresis, focal neurological deficit. Focal neurological deficit sometimes could find positive in patient with seizures. Mental status, some of the patients who have seizures, or most of the patients who have seizures, they have postictal phase, so they will be confused, but usually in syncope attack, the patient completely back to baseline within a few seconds. So that's conclude my part, and now I'm going to hand over to my colleague Tibyan to continue. Thank you.
Hello, everyone. Thank you, Dr. Nader, for this opportunity. Can you hear me, everyone?
Yes, we can hear you clearly.
My name is Dr. Tibyan Abdalhamed, and I'm going to present the evaluation of syncope. Okay. So we will start by talking about history. As accurate recall of the syncopal event is frequently inadequate because of the high prevalence of cognitive dysfunction in older population. So, additional history, if possible, should be obtained from the person who witnessed the event. And we need to ask a question: did the patient suffer from a true syncopal event, as opposite to dizziness or disequilibrium? And false. Because false are more common in older adult, it's important to differentiate between the accidental false and the syncopic one. And when we are taking the history, we need to take in consideration any precipitating factors like eating, urinating, coughing, emotional stress, or physical exertion. As well, we need to look for any prodromal symptoms like chest pain, palpitation, dizziness, diaphoresis, nausea, and vomiting. As well, one of the most important aspects in the history taking we need to check the medication. How, when, and what medication does the patient take? And we need to pay a close attention to any medication that can cause bradycardia or hypotension. Also, when taking the history from the witnessed person, we need to ask about the duration of the event and the appearance of the patient during the event. Was he lying flaccid in tone or motionless? If there is any abnormal movement or lip smacking or loss of urine incontinence, so that we can differentiate between the syncope and other differential. Also, we need to take a proper history regarding the comorbid condition like diabetes mellitus, if the patient have a history of Parkinson's disease or coronary artery disease. We have also a score called EXIT score that can help us to predict if the syncope is caused by cardiac cause. And as it's shown in this table, it's a score have multiple variables like palpitation, preceding syncope, heart disease with abnormal ECG. And after calculating the score, if the score is equal or more than 3, it will be associated with a higher rate of a cardiac syncope. Now, let's talk about the physical examination. We need to do a thorough examination, especially we should focus on the cardiovascular and neurological areas, and if there is any concern have been raised during taking the history and examination. Starting by doing the blood pressure and pulse, we should measure them in both arms in the supine and standing position after 1 to 3 minutes. Also assessing the carotid pulse examination, as any delayed upstroke and low volume may identify aortic stenosis. And then when we are performing the carotid massage, we need to consider that there is an ECG and resuscitation equipment available. As well, we need to know if there is any relevant contraindication like carotid bruit, cerebrovascular disease, or recent MI. Also, continuing the cardiac examination, looking for any abnormal heart sound like murmurs. And regarding the neurological examination, we need to assess for any focal deficit, and we need to do an assessment for cognitive function, visual acuity, coordination, and gait. Then, let's talk about the diagnostic testing. The following slide will review various diagnostic tests that are available for the evaluation of syncope. And it's important to remember that not every test is required, because we need to take adequate history and do a full examination so that it can help us to determine an appropriate test. And here is a couple of evaluations that can help us to reach the specific diagnosis and the cause of the syncope. Starting with doing the orthostatic vital signs, checking the blood pressure, and to measure the difference in the drop, like more than 20 in the systole and more than 10 in the diastole. Doing the gait evaluation, as well, doing the carotid sinus massage as it reproduces the symptoms. And as I mentioned earlier, we need to put in consideration if the patient have any contraindication like carotid bruit or recent stroke. As well, we need to do a laboratory testing, assessing for any hyperglycemia, electrolyte disturbance, anemia, and occult blood. Also, we have the resting ECG to assess for any arrhythmias or prolonged QT, doing the echo to show if there is any findings of aortic stenosis, left ventricular outflow tract obstruction. As well, we have the ambulatory 24-hour blood pressure monitoring, as did in our case earlier. And also we have the Holter monitoring and the implantable loop recorder for arrhythmias. Also, one of the investigation, we can use the head-up tilt table test that can help us to reproduce the vagovagal syncope. As well, there is electrophysiological study. Moreover, we need to do a validated depression assessment, as syncope is more common in depressed patients. Finally, we can do an evaluation for autonomic nervous testing, assessing for any findings of autonomic nervous system dysfunction, and we can do the EEG as a diagnostic for seizure. Now, we need to ask a question. Is hospital admission required for any patient with syncope? So, we hospitalize patients who are at increased risk for adverse event. And here is this table that show the risk factor that, if present with the history of syncope, will show that the patient is having more adverse event and we need to admit him. Like if the symptoms is follow it with chest pain, palpitation, GI bleeding, if there is any cardiac history of coronary artery disease, heart failure, and if there is any family history of first-degree relative sudden death, and the physical examination show any signs of tachypnea, hypoxia, abnormal heart sound or murmurs, and ECG readings was abnormal, and if the laboratory findings are like showing hematocrit less than 30% or occult blood, we need to consider that this patient will be at higher risk, and we need to consider admitting him to the hospital for more investigation. And by this, I would be finishing my part. Thank you for listening. And now Dr. Hashim will continue. Hello?
Thank you, Dr. Tibyan.
Hello, everyone. Sorry for the
floor is-
delay, some technical issues. Hello, everyone. My name is Hashim, and I will be presenting the treatment and prognosis part. So, in treating syncope, we focus on some things here. So we have the main goal is to improve quality of life and prevent injuries, physical injuries, as most patients are elderly. So we focus on treating the underlying disorder in older patients. Treatment of multiple possible causes often necessary. So review of medication list for potential culprits like alpha antagonists, vasodilators, clonidine, and vasopressors. So any medication that can cause low blood pressure leading to syncope. Also, discontinuation of medication that increase the risk of syncope is always an early step. So we can start by the treatment of reflex syncope and postural hypertension. So we have some non-pharmacological measures with physical counter pressure maneuvers like leg crossing, arm tensing, hand grip, and buttock clenching can induce a significant blood pressure increase during the phase of impending reflex so that the patient can avoid or delay losing consciousness. Also, compressing stockings and abdominal binders can be used, as well as smaller and frequent meals can be effective in patients with postprandial hypotension. Also, we have some medical treatments for postural hypertension and syncope. We have midodrine, which is an alpha agonist. It works by increasing vasoconstriction and reducing syncope recurrence. It needs to be used with caution, may cause supine hypertension in those with decreased vascular compliance. In men, it may exacerbate lower urinary tract symptoms due to prostatic hyperplasia. So we need to monitor blood pressure response and symptoms. Also, we have pyridostigmine, an acetylcholinesterase inhibitor, increases both standing blood pressure and peripheral resistance. One of the adverse effects is abdominal cramps, diarrhea, and urinary urgency. So it needs to be used with close supervision in older adults and may not be tolerated by the adverse effects. Also, we have beta blockers, may be useful in older patients with vasovagal syncope, but however, beta blockers in the general population appear to have no significant reduction in syncope. Continuing medical management, we can do volume expansion with added salt of fludrocortisone. Both increase renal sodium retention and intravascular volume, may be effective in patients with persistent postural hypertension. So, a role of a pacemaker. So the mainstay of treatment for sinus node dysfunction or high-grade AV block. So any patient who has a cardiac cause of syncope and arrhythmia in particular. So permanent pacing is indicated when syncope or near syncope is correlated with bradycardia. Also, we have to pay attention for medications that cause bradycardia are often used for treating significant cardiac conditions like beta blockers, which can lead to bradycardia, stycolinase inhibitors, which might lead to increased parasympathetic tone and also leading to bradycardia, which are used in dementia. Also, risk and benefits of continuing and discontinuing these medications must be discussed. So it's not recommended in patients with unexplained syncope or falls without documentation of bradycardia. So syncope public reporting. When should a syncopal episode be publicly reported? So syncope while driving is uncommon, but many states have laws restricting driving following a syncopal event. So clinicians should familiarize themselves with local driving regulations on syncope. So prognosis. Prognosis depends on the underlying cause. We have cardiac causes which have the worst prognosis. So the 1-year mortality rate is 18% to 33%, with death chiefly due to the underlying disease, not the syncope itself. We have the non-cardiac causes, which have a 1-year mortality of approximately 6%. Also, neurally mediated or vasovagal syncope, which are vasovagal mechanisms as the cause of syncope, approximately 20 to 30% of patients more than 65 years of age. So some suggestions that vasovagal syncope in all the others is often associated with comorbid illness that can increase the overall mortality. So as you know, most of the patients with syncope are elderly patients that might lead to an increased mortality rate. No cause found in approximately 10 to 20% of syncope patients. So prognosis for these patients is no worse or better than that of the general population. So this is a table showing the risk factors for adverse prognosis in syncope. As my colleague mentioned earlier, these are the risk factors that might lead to adverse prognosis in syncope. I'm not going to mention them, as she mentioned them earlier in the part of evaluation of syncope. So we had a case scenario earlier in the presentation. The young patient with the loss of consciousness, he was diagnosed with asystole. So what do you think is a definitive management for this patient? What do you think, guys, is the definitive management for this patient? Any ideas?
He may need pacemaker.
Well, what do you say?
Pacemaker. He needs a pacemaker.
Yes, exactly. So patient with asystole and arrhythmia, the definitive management is a permanent pacemaker. So anytime he gets the arrhythmia, the pacemaker comes in and corrects the rhythm of the heart. So we have two more case scenarios. We have a 72-year-old man. He comes to the office because he has fallen several times in the past year. He has felt increasingly less steady when he walks. He now leaves home infrequently. He has lost consciousness 7 times in the past 2 months. He has no prodrome. According to his wife, in each episode, he rose from bed after taking a nap and then suddenly collapsed to the floor unconscious. He remained unconscious and still for 10 seconds before regaining consciousness and full control of his body. His medical history includes advanced Parkinson's disease, transient ischemic attacks, hypertension, diabetes mellitus. His medications are aspirin, carbidopa, levodopa, metformin, lisinopril. There have been no recent dosage changes. So in examination, his blood pressure is 110/80, supine, and 100/80 standing, with no change in heart rate. Mental status examination, kidney function test, and strengths are normal. There is masking of faces, mild cockwood rigidity in the wrists, bradykinesia, and loss of vibrator sensation in the feet. Ankle deep tendon reflexes are absent, and his gait is slow. ECG and echocardiography findings are unremarkable. So which one of the following is the most likely cause of his loss of consciousness? So guys, what do you think is the most likely cause of his loss of consciousness? Any ideas?
B is the answer.
B, dysfunction of autonomic nervous.
That is correct, because this patient with advanced Parkinson's disease most likely has dysfunction of his autonomic nervous system.
Which is
We have
called
a
the
70
multiple system atrophy.
Yes. So another case scenario is a 70-year-old man comes to the ER because he lost consciousness earlier in the day. The previous evening, he was at a social gathering where he drank more alcohol than usual for him. When he woke up this morning, he went to the bathroom and while urinating collapsed onto the floor. His spouse witnessed the event and did not notice any abnormal movements. He regained consciousness after 10 seconds without alteration of mental status. There was no head injury, he had no prodromal symptoms, and currently feels well. Medical history is hypertension and diabetes mellitus. He is on lisinopril 40 milligrams, metformin 1 gram. Examination, temperature, blood pressure, neurological findings are all normal. So which of the following is the best recommendation for this patient? So what do you guys think is the diagnosis first in order to find the recommendation? So this patient, he had syncope episode while urinating. So this is most likely to be what?
Situational syncope.
Vasovagal. Vasovagal.
So the best recommendation is what for this patient?
Sit during.
Sit during urination.
Yes, sitting during urination. This is most likely to be a situational syncope. So the best thing is to try to avoid the trigger causing the syncopal episode. So in summary, we can say that in older adults, the cause of syncope is often multifactorial, and it's important to know your local driving regulations pertaining to syncope. Also, it's important to review the medication list of each patient, as medications are commonly implicated as a source of syncope. And also, most diagnostic procedures for syncope are expensive and have a low yield unless findings from the history and physical suggest a particular cause. And at the end, it's important to rule out cardiac condition as a cause of syncope, as they are associated with worse prognosis, and treatment of syncope focuses on treating the underlying disorder. By this, we end our presentation of syncope. I thank everyone for attending this, and thank you very much for your time and your participation, and I hope this was a useful presentation.
Thank you so much, Dr. Hashim, Dr. Shroog, and Dr. Tibyan for this insightful presentation. So if anyone have a question, you can ask directly or you can put them in the chat below before moving to our next topic.
How depression can lead to a syncope? Is it due to medication or another cause?
Okay.
Sorry, can you repeat the question again?
How depression can lead to syncope? Is it due to medication or another cause?
Well, I haven't heard someone with depression had syncope because it's mental thing, but I know that antidepressants such as tricyclic antidepressant they have anticholinergic effect that can lead to syncope. If in the elderly patient, usually young people can compensate, or it could be functional, by the way, because some of the depressant people they have like psychotic things. So it's up to my knowledge. If anyone can share.
I don't think it's just that most patients that come with syncope are elderly, so it's routine to screen for depression in elderly. I think that's the correlation here. Maybe I don't know.
It's exactly like this.
Thank you for your great presentation. I just want to highlight the differentiation between syncope and seizure, because there may be overlap between these two different pathology. We have something called convulsive anoxia, which can occur in syncope. And the second overlap syndrome is the drop attack, which can occur also in seizure and in syncope. Drop attack is loss of tone without loss of conscious. It can occur in atonic seizures and it can occur in syncope due to posterior circulation hypoperfusion as well. Thank you.
Thank you so much.
Okay, if there is no further questions, we can move forward to our next topic, supporting Alzheimer caregivers, presented by Dr. Mohamed and Dr. Alrasheed and Dr. Osman. The floor is yours.
Hello, Assalamu alaikum. My name is Dr. Osman, and today, me and my colleagues will present to you supporting Alzheimer caregivers. So this would be an interactive guide for IMGs to provide a compassionate and effective support for those caring for individuals with Alzheimer. If you could just allow me a minute to present PowerPoint.
If you have any issue with your laptop, I can share my screen. I have the presentation.
Yes, please, Dr. Mustafa.
Sure. Okay.
Okay, thank you, Dr. Mustafa. Okay, again, I'd like to introduce myself. I'm Osman Siddig. Today, me and my colleagues will present to you a presentation about supporting Alzheimer's caregiver. This is meant to provide a compassionate and effective support, especially for those caring for individuals with Alzheimer's disease. So our objectives for today will be understanding the unique burden on Alzheimer caregivers. Okay, learn how IMGs can provide culturally competent support and gain skills to assist, communicate, and advocate for those caregivers, and also explore real cases and practice solutions interactively. So, as a quick recap, Alzheimer's disease is a progressive neurodegenerative disease marked by memory loss, impaired thinking, and behavioral changes. So, as we know, Alzheimer's disease is a very common disease. So, most of us would know a patient or even a family member with this disorder, and it's very, very prevalent. According to the global stats of WHO, for 2024, that 55 million people are living with dementia, and 70% of those have Alzheimer's disease. 75% of those with dementia in general have a caregiver who's an informal caregiver or unpaid caregiver. So this would lead us to the next part we can talk about is who are those caregivers? Usually, those caregivers are a spouse or an adult daughter or even an extended family member to those caring for this type of patients. And usually, most likely, they have no formal medical background. So you could understand that why this is a problem and why we need to support them and we need to provide the meaningful skills and even mental support to these kind of patients. Another thing is that most of these caregivers are usually old patients themselves, and they have chronic illnesses. Okay, so in a multicultural setting such as the US, these could cause like many problems such as facing language barriers or even visa stress or immigration-related isolation. So this is why it's important for international medical graduates in general that to support and help these kind of patient and to provide even a cultural appropriate type of care. So common caregiver challenges, we could find that they have a quite range of dimensions of burdens, such as an example, we could have an emotional one, which there could be a grief, because it is hard for anyone to see one of their family members or loved ones to grow old and even facing problems with their memory, not able to recognize certain close or family members or even friends. And it's also a problem because it could lead to frustration, as they would need help even in the daily needs, such as bathroom and other, and even feeding them. And this could also lead to a sensation of guilt. So we could understand that why this is an emotional burden, but that's not all. Could also lead to a physical burden, which could lead to fatigue, because as we know, Alzheimer patients usually have a symptom of wandering in the night, which means that these caregivers would have to wake up in the middle of the night to care for them. And this would lead to fatigue in the next day, and also even insomnia and other sleep disorders. Also, these caregivers would have to carry them around for a good amount of time. This could lead to back pain and other physical symptoms. Another issue is financial issues, because these caregivers should also care for those patients. They will most likely have to quit their jobs or even to stop whatever they're doing to free themselves for them. So this could lead to a very financial burden situation. And also we have a medication cost, which could be hefty on them. And as you know, even a Alzheimer patient needs another things like diapers and transportation equipments and other things. This would also lead to social isolation and even loss of identity. Okay, according to the Journal of American Medical Association for 2022, they found out that caregivers have a 63% higher mortality rate than non-caregivers under chronic stress. Now, this is not just a statistic. This is a huge number, and this is a huge kind of disorders that would attack these patients or caregivers, such as could start anywhere from increased cardiovascular risk of diseases, to many other situations and many other stress-related problems. And hence, this caregiver would need a very composite care in order for them to carry their duties. And also another note for physicians in general, that you might actually be the first healthcare provider to ask these caregivers that how they are doing, because it's always about the patient, and sometimes we forget these caregivers and what burdens and what problems they face from day to day. So it's crucial for us to understand those caregiver journey by using firstly an empathetic language. We should understand that these caregiver roles isn't static. It's constantly evolving from mild memory prompts to full assistance with daily living. So acknowledging this spectrum of duties is essential, and to approach them with conversation using an empathetic and understanding language is a cornerstone for our approach to them. So we would like to frame discussions positively. We would avoid terms like burden and others. Maybe use something like, quote, "I can only imagine how challenging this must be." And also offering flexible suggestions, such as advices with phrases like, "if possible," or "some families find it helpful to do this and that." And also provide specific resources, like always give them a phone number or a website or something they could reach out to find a specific answer for their questions, not just a general advice. So we'll also speak today about the 6 core of practical support strategies. So the first thing is we would like to recognize the caregiver burnout early on. We would look for symptoms such as anger, exhaustion, crying easily, and poor self-care. We have to see these kind of stuff early And also, we have the duty to give those caregivers the appropriate care they need, not only the patient. Another thing is, or the second point is to offer a practical support, for example, as suggesting daycare programs and connecting them to local Alzheimer orgs, and also help them to apply for benefits if applicable. Okay, so this is the end of my part. I would hand the mic to Dr. Mohamed to continue the presentation.
Hello, my name is Mohammed. Am I audible?
Yeah, Dr. Mohammed, your voice is clear.
Yeah.
All right.
Okay. You can start.
So my name is Mohammed Awad. I'll be continuing from the other practical support strategies that are aimed towards the caregivers. And our third point here is to clarify treatment and symptom management. Excuse me. Alzheimer's is a lifelong condition with ups and downs, and caregivers naturally hope for a cure. Before diving into practical tips, it's helpful to acknowledge that even with the best medications, Alzheimer's will change over time. So there are fluctuations, might get or feel better after some time, might not, might decline, so on and so forth. Your role as an IMG is to share honest, simple information that balances hope with reality, so families can plan, feel empowered, and avoid false expectations. Branching into that, we can explain or start by explaining how Alzheimer changes over time. As I just mentioned, each person's journey is different. Symptoms may stay the same for weeks, then suddenly change. Emphasize, you as the IMG towards the caregiver, emphasize that it isn't a straight line. There are good days, there are bad days, and that's normal. You have to set realistic expectations for medications. Drugs, for example, can ease memory and behavior issues and may slow decline, but they won't cure Alzheimer's. A great analogy to take in this piece of information or pass it on is to think of them like glasses for your brain. They help you see better, but they don't necessarily fix your eyes. Another important point is to provide symptom and treatment lists. List common medications with bullet point effects and side effects. Define medical words in everyday language. Avoid medical jargon. Keep it simple for them to understand. So, if, for example, incontinence means leaks you can't control. You can as well educate on common medical problems that usually the caregivers would have to deal with. For example, fever, infections, dehydration, incontinence. It's very simple to just give them a little bit of instruction, take the temperature, encourage fluids, call the doctor. Any dehydration, usually these caregivers are not very well educated when it comes to these things. They don't know when something is really serious or not. So giving them that little bit of insight on how to deal with the medical problems will go a long way. So for example, in dehydration, offer small sips of water, herbal tea, popsicles throughout the day. For incontinence, use easy wear pads and set a bathroom schedule every 2 hours. Moving on to the next point, we have some home adaptations, things that can be dealt with within the household of the caregiver and the patient or the family themselves. As Alzheimer progresses, familiar rooms can suddenly become confusing or dangerous. A few straightforward changes to the home environment can dramatically reduce risks, ease caregiver stress, and let families focus on quality time instead of constant supervision. These low-cost strategies require minimal skills or tools, and they often send a powerful message: safety is caring. And you know what they always say, safety comes first. We can hear a few tips and tricks that caregivers could try and bring it to their households. For example, by starting by eliminating fall hazards, removing any tape or loose rugs, rerouting or covering electrical cords along walls, keeping walkways clear of furniture and clutter to avoid any tripping or anything like that. Brighten the hallways or any walkways around the house. Install night lights or motion sensor lamps in hallways, bathrooms, and staircases, using contrasting colors on steps and door frames to help with depth perception. These are all things that could be done around the house, and they help in a way in dealing with a patient that's struggling with Alzheimer's. You could lock up dangers, starting by storing medications, cleaning products, sharp objects in cabinets with child-proof locks. Keep harmful items out of sight, ideally in a separate labeled area. Add simple monitoring. A basic baby monitor lets caregivers hear wandering at night. Patients with Alzheimer's generally have a tendency to move around without anybody really paying any attention to them, and they are not really aware of what they're doing. So just being able to pay attention to, or constantly monitor them eases out the stress of dealing with a patient or dealing with a family member. As well as, for example, door alarms or adhesive sensors can alert caregivers to unsupervised exits to prevent them from wandering off or leaving their designated area or where they're supposed to be. Labeling and simplifying as well, putting clear large print labels on drawers, for example, for socks or plates to help in orientation. Using pictures instead of words where possible. Another one is the guide to financial support. Introduce programs like elder care locator or welfare services for home safety grants. Many communities as well offer assistance for grab bars, ramps, or motion lights. And these are all things that could be integrated into a household to ease the strain on the caregiver, and as well provide support for the patient or the person dealing with Alzheimer themselves. And now I'll be passing the stage to my colleague, Dr. Mohamed, and thank you very much for this opportunity.
Thank you, Dr. Osman and Dr. Mohamed, and good evening, everyone. This is Mohamed Alrasheed. So thank you, Dr. Mohamed, again for highlighting the importance of recognizing the caregiver burden and offering a practical home-based support. So building on that, I will now walk you through the more advanced stage of a caregiver support, specifically when medical intervention becomes necessary, and how we as international medical graduates can guide families through difficult but critical transition. So the first thing is to recognize when medical support is needed. So one of the most difficult decisions a caregiver may face is transitioning their loved one to a long-term care facility. This decision itself often comes with guilty, sadness, or even sometimes feeling of a personal failure. So as a clinician, especially international medical graduate working in a diverse community, our role is to normalize this conversation with empathy and without judgment. So can you move next, Dr. Mustafa? Okay. So how we can help? We can help by identifying clear red flags, such as if the patient is failing frequently or attempting to leave the home multiple times, or sometimes the patient or the Alzheimer patient may show signs of aggression, or even if the caregiver itself own health is declining, it may not. These signs mean that this is the right time to go to a more advanced care facility. And these signs are not signs of failure. These are a sign that more support is needed. So the next thing we should do is to validate the decision. So it's crucial that we validate the caregiver experience and reassuring them that seeking professional help is not abandoning their role. It's just a part of continuing it with loved one, but in a responsible way. So we have to say things like this is not, and this is not giving up. This is making sure that your loved one is safe. Or we can try to say that many families feel the same way. You are not alone. So we have to validate the decision of transferring the patient to a care facilities. And lastly, we should provide reassurance or resources for a care option. So many caregivers simply don't know where to begin and where they should go. This is why we can help. We can help by offering brochures or connecting them to the case manager or social workers, or explaining the financial option like Medicaid or long-term care insurance. This ensures them that to visit facilities and ask about dementia special care, for example, and by this we empower them with more information regarding the options. So lastly, we should emphasize caregiver self-care. So we should not forget that our caregivers are also patients, and many of them neglect their own health while caring for others. So they need our support also. So we can do this by encourage healthy habits. Next. We can do this by encourage healthy habits, such as start 10 minutes walk every day, or drinking water regularly, and preparing simple nutritional meals, and taking short break for prayer, for medication, or for deep breathing. And we should emphasize that these are acts of strength. These are not selfishness. Yeah. So we should prioritize their own health. Just simply, we can ask them directly, when was your last doctor visit? Or you should ask them, are you sleeping, eating, or feeling okay? We should be the one who noticed these, and we shouldn't wait for crisis to support the caregiver health. So we have to recognize these early. So, and also we have to discuss respite care option for them. By respite care, it's include everything, whether it's a few hours from home as aid, or short stay at care center. These can help prevent burnout and let them know that it's okay to have a rest, and taking a break is a part of good caring, and we should normalize this service to them. And finally, some caregivers feel more confident after structured training. So we have to recommend a program. We have to recommend programs for Alzheimer Association, for example, or a local workshop in a hospital, or things that can help them managing behavior, like meditation or wandering with more confidence. So these boost confidence in the handling behavioral symptoms, like I said, in aggression or wandering. So let us wrap up with some key points that Dr. Osman and Dr. Mohamed mentioned. So the first thing, caring for Alzheimer is demanding physically, emotionally, and socially. And as international medical graduate, we play a unique role by bridging cultures and explaining care options. We should use respectful, clear language and providing written tools and normalizing long-term care and breaks. And most importantly, always check in the caregiver, not just the patient, as I said. And sometimes the most healing thing or the simple thing that you can do is simply to ask, how are you doing? So before we go to our final case scenario, here are some useful resources such as useful resources for caregivers such as the Alzheimer Association or local support group such as governmental social services or Educare locator. And for those who have language difficulties, especially the immigrant, Arabic language dementia guide. So moving to the last slide, we have this case scenario. This is Mrs. Alia Karim. She is a 52 years old daughter caring for her 78 years old father who has a moderate Alzheimer disease. She tells you she's sleeping only 4 to 5 hours a night and has frequent headache, and she feels guilty whenever she takes a break. She speaks limited English and is hesitant to ask others for help because this is my family duty. So the question is that as international medical graduate clinician, what is the best next step to support Mrs. Karim? Is it help her supplying for the local Alzheimer daycare program and schedule a briefing respite visit, or encouraging her to keep caring at home without outside help, or referring her father immediately to memory care facility and arrange a placement next week, or prescribe an antidepressant for Mrs. Karim and ask her to return in a 1 month. So what should be the most appropriate step?
A.
So let's take another answer. Okay. So yeah, as you said, the correct answer is A. This is option gently support the caregiver and respect her cultural value and introduce practical help. She needs relief and she needs someone to normalize the rest for her and guide her toward community resources. So the thing that I want to emphasize here, let's remember that our role isn't just to treat the disease, it's to support the families. This is what we should do every time, and we have to memorize this. So this is the end of our presentation. If anyone have a question, we are welcome to answer your questions.
So thank you, Dr. Mohamed Rashid, Dr. Mohammed, and Dr. Osman for this informative presentation. It was really helpful. So as there is no further questions, we can move to our next topic with Dr. Iman Adam, which is conferences. Dr. Iman, the mic is yours.
Hello, everyone. My name is Iman Osman, and today I will be presenting a conference. Let me share my screen. Okay. Introduction to conferences. Our objectives today is the definition of a conference, the purpose and importance of conferences, benefits of presenting at a conference, how to participate in conferences, tools to find conferences, funding and scholarships, and appropriate conferences in geriatrics, and conferences in other specialties, and my experience in conferences and my abstract. Definition of a conference. A medical conference is a formal gathering of healthcare professionals, researchers, and students where medical topics are presented, discussed, and explored. These conferences aim to share the latest research, clinical practices, innovations, and advancements in medicine. The key features are presentations of new research and case studies, workshops for skill development, lectures by experts and specialists, networking with peers and industry leaders, poster sessions to showcase ongoing or completed research. The purpose is to enhance medical knowledge, improve patient care, and encourage collaboration in the medical community. The types of conferences according to location, we have local on a institutional level, national limited to a country, and international on a global scale. The purpose and importance is to share latest research and discoveries, present case studies and clinical trials, discuss medical advances and innovations, promote evidence-based practice. The importance is that it keeps healthcare professionals up to date, improves patient care through knowledge exchange, builds a global medical community, and supports young researchers and students. The benefits. Number one, we have networking opportunities, where you could meet professionals, experts, and peers in the field that you are interested in to build collaborations, connections that may help your career or research, and exchange ideas and contact. Excuse me? Can you hear me?
Yeah, Dr. Iman, we can hear you clearly.
Exchange ideas and contact details for future opportunities. Two is knowledge sharing and learning. Learn about the latest research, trends, and technologies. Gain new insights or perspectives that you may not get from books or online, and ask questions and get experts' opinions in real time. Presentation and communication skills. Presenting your work improves your public speaking, clarity, and confidence, helps in refining your ideas through feedback from the conference, and adds to your resume or academic profile, academic and professional recognition. It enhances your CV, especially if you present or publish an abstract, shows you are active and engaged in your field and you're interested in the field that you're presenting in, and it may lead to awards or invitations to publish in journals. Career advancement. Learn about job openings, internships, or scholarships, basically new opportunities that you might have not had if you did not present in this conference. You meet potential mentors or employers and discover new career path you haven't considered. Motivation and inspiration. Exposure to passionate people and groundbreaking work can reignite your enthusiasm. Attending conferences, you may meet professionals that may inspire you for your own future goals, and it helps you stay focused on your goals. Culture and personal experience. If you're traveling to different countries for a conference, it is an opportunity to explore a new place, and experience different academic and professional cultures. How to participate? Number one is to find a relevant conference according to the field that you want to present your abstract. You have to check the eligibility and requirements. You could register online, submit your abstract. You wait for your email. Once you get your email and it gets accepted, and you should prepare your presentation. If you are planning to travel, prepare your visa. If you're planning to go online, prepare your mic and the way you're going to present and your PowerPoint. Number 7 is plan travel and accommodation, attend sessions and take notes, network with attendees, engage in Q&A and discussions in the conference, visit exhibitions and workshops. If the conference is offering workshops, collect participation certificates and follow up with contacts after the event if you meet any professionals. This might be very important for your field. How to fund conferences for your area of interest, societies in your area of interest. There's a library guide, publication houses like PLOS and Elsevier, and search tools like Conference Alert. Funding and scholarships. You could find conference travel grants. Some organizations can provide you with these. Registration fee waivers. Some conferences where you could submit your abstract, they give waivers to low and middle income countries, or either waivers or discounted rates. Some universities or institutions provide waivers or provide grants for conferences to increase research in the university. You could also find support from NGOs or government programs. I know that the WHO also offers some funding. And importance of early applications. Some conferences, they have early bird grants, or where if you apply your abstract earlier, you could get a discounted rate. Search tools, we have Conference Alert tool, where you could go on this link, and then you could put your country, the country that you want to present in, or your locally. You could choose your category according to your abstract, and you could also choose the topic, and it shows you the available conferences where it's still open to submit your abstract. Search tools. We also have a surveyor publication house, where you could also find more conferences. This is the geriatric conferences and annual meetings. This is presented by Dr.Mohamed Salim. We have the Gerontological Society of America, where they have also annual conferences associated to geriatrics. We have the American Geriatric Society, the Alzheimer's Association International Conference, and International Association of Gerontology and Geriatrics. These are all open right now. You could also search for conferences in other specialties like cardiology, pulmonology, and etc. They're, according to your abstract, you could find conferences in all these specialties. My experience in conferences, I have submitted 3 abstracts in total to 3 different conferences. 2 got accepted, and one got accepted in the International Conference of Preventive Medicine and Public Health, the second in the European Nephrology Conference, and the third one got rejected, which was submitted to Stanford. Thank you. And if we have any questions, I will also present my abstract. Do you have any questions? Hello?
Yes, we can hear you.
Okay. Okay, this is one of my abstracts that I have submitted to a conference, and it got accepted. I just want to present it today as well. It is about the clinical characteristics and predictors of mortality among children admitted to the pediatric intensive care unit, which was a 5-year hospital experience. Introduction, intensive care units are crucial for managing critically ill children, with King Faisal Hospital in Kigali playing a key role in Rwanda's healthcare landscape. This study aims to describe the demographic characteristics, primary diagnosis, length of stay, predictors of mortality, and mortality rate among pediatric patients admitted to the intensive care unit. Methods, we conducted a 5-year retrospective study at King Faisal Hospital from June of 2019 until June of 2024. A full coverage sampling technique was used. We collected a total of 274 pediatric patients' paper-based register records. The checklist used in the study recorded the demographics, admission details, procedures done in the intensive care unit, and outcomes of pediatric patients in the intensive care unit. We then analyzed the intensive care unit patient data using descriptive statistics and cross-tabulation to examine baseline characteristics, gender, length of stay, and reasons for admission. Stepwise logistic regression identified factors associated with higher mortality risk. The results, the baseline characteristics, out of the 273 patients, 139 were female and 134 were male. The overall percentage is not significantly different, with females being slightly higher. The age varied between 0 and 16 years with a mean of 5.02, and the predominant age range was 0 to 3 years, which is shown on in table 1. The length of stay, the average length of stay was 8.93 days. The longest recorded length of stay was 185 days due to respiratory causes. There were no statistically significant differences in the mean length of stay according to gender. The causes of intensive care unit admission, respiratory conditions were the most common. The most common respiratory causes for admission were respiratory failure, pneumonia, and bronchitis. Patent ductus arteriosus was 11.7% of all cases. Convulsions accounted for 4%, and there were no statistically significant differences between genders according to these diagnoses. This is a table that shows the general distribution of diagnosis grouped according to the ICD-10 chapters. As you could see, the respiratory system disorders were the most common. Results, the predictors of mortality. There was a strong association between mechanical ventilation and mortality rate, as indicated by a coefficient of 1.237 and an odds ratio of 3.445, shown in table 3, meaning patients who received mechanical ventilations are over 3 times more likely to die. This effect is statistically significant with a p-value of 0.0001. Highlighting mechanical ventilation as a crucial predictor of mortality, and there were 57 deceased patients, making the mortality rate 20.8%. Conclusion, the study highlights the significant burden of respiratory illnesses among pediatric intensive care unit admissions at King Faisal Hospital, with children under 3 years being the most affected. Mechanical ventilation was a strong independent predictor of mortality, emphasizing the severity of cases requiring this intervention. The overall mortality rate of 20.8% reflects challenges typical of resource-limited settings. These findings underscore the need for early identification of high-risk patients and improved critical care strategies to enhance survival outcomes in pediatric patients. Thank you. If you have any questions, go ahead.
It's a great presentation. Thank you so much, Dr. Iman. You guys can use this file, this presentation, without searching furthermore or digging in the internet. I just want to remind you that you can find these presentations in the app. Feel free to use them. Again, we want to thank you all doctors for this informative and straightforward, without a lot of chit-chatting. Those doctors worked hard really to make this presentation to be this informative and straight to the point. So finally, we have Dr. Mohamed Salim, which will give us some tips into how to find an IMG-friendly programs, residency programs. So, Dr. Mohamed Salim, the mic is yours.
Hi, hello everyone. Can you hear me?
Yes, we can hear you.
Okay, that's great. First of all, I just want to say thank you for giving me this opportunity, Dr. Nadir, and for everyone. And I really hope the session that I'm going to give you to be at least informative, because I know some of you guys are really find it some sort of like hectic to apply, especially this year or next year. So I'll just try my best to give you tips into how to find the perfect programs to apply to. And I will share my screen now. Okay. Can you see my screen?
Yes, we can see.
Okay. So, I don't know how to minimize this. Ooh, yeah. No, I don't know. I don't know if you can see the control panel at the top. If you can see that, just try to ignore it because I don't know how to remove that. So yes, I'm gonna start by saying that if you are already in the process of making your list into which programs that you're applying to, I'm not here to change anything that you are used to. I'm just here to tell you some things that might be helpful in making that step much easier. So when it comes to searching for programs to apply to residency to, there are two main websites that you need to look at. You have the Residency Explorer and you have Freida. These are the two main ones that you can use to know better about the programs, the percentages of the IMGs in there, and just any kind of details that you're looking for. So I'm gonna start with talking about Residency Explorer. It's basically a website that you need to do an account to be able to view the programs. It's something that is extremely easy. You just make an account, few steps, and in a couple of minutes, you're good to go. After that, when you go to the main page, this is the main page basically. You just click in, and once you're signed in, you can choose based on the specialty that you are applying for. It's just taking a few minutes to load. Yes, so this is the main page, okay? You can tailor your profile according to what you're looking for, or you can use this website objectively, you know what I mean? So if you want to tailor your experience based on your profile, that's okay. But for all the intents and purposes for this presentation, I'm just gonna make it as general as possible. But I'm gonna walk you through what you can do in my profile page. So once you are here, you can literally, sorry, you can literally change everything to what you are looking for, from the program characteristics, literally from the training length. type of the total residents in the program, the total residents entering the cohort. You can change the education and research opportunity that you are looking for. For example, if you are looking to apply to programs that are more in the academic field, or if you are willing to work as a hospitalist after you graduate, primary care, research track. Also, you can change the program offerings. You know, if the program is offering you the opportunity to support you in USMLE Step 3, debt management, alternative complementary medicine curriculum, anything, like literally you can select and match anything according to your need. So this is concerning the education and research opportunities. You can also change anything that is related to employment benefit, the minimum salary that you're looking for, anything that is related to the benefits that the program is willing to give you, like free parking, housing, moving allowance, or even like a housing stipend. The practice environment as well, you know, if it's a community-based, university-based, community-affiliated. And I think the most important thing here is the resident demographics and backgrounds. So here you can give the website a percentage of the minimum percentage of non-US IMGs in the program that you are willing to apply to. So for example, you can choose like at least 10% of the people working in that, 10% of the residents in that program to be non-US IMGs. So you can do that from here. But also you can choose to be 0, for example. Or you can choose it to be empty. You can choose to be, for example, 50%. So you can change that according to what you are looking for. But also, as I said, for the purpose of this video, I'm gonna make it plain. So I tell you, like, even if you want to take an objective approach, you know where to look. So yeah, we're just gonna stick to 0. But also, if you change anything here, in the main page where you can explore the residency programs, it can give you, like, for example, this program matches 7 out of 7 of the things that you selected. For example, let's say the 7 things that you selected is free parking, 10% non-US IMGs, it's university-based, you know, anything that you choose as a criteria in the residency page, it shows you like how this matched to your profile. But if you don't choose anything and you click save, it just gives you like the list of all of the programs. Either way, it's going to give you the same list of all of the programs. But when you choose things in the My Profile part, it will show you in the residency part if this matches to your profile with how much points, basically. So we're going to go to Explore. You can say I was already working on my list, but I'm just gonna, I want to change it to be very, very basic. I don't know how to do that way. Yes. So let's say I'm applying to pediatric, which is true. I'm applying to pediatrics, inshallah. So yeah, you change the specialty you're applying for from here. You can select as many as specialties as you want. So let's say pediatrics, for example, for this video. It's not a video, it's a presentation. I'm sorry. So yeah, so you get this list, okay? And also you can view everything that is related to the program at the interface. You can also choose to display the applicant type. Here, in the default setting, you get all of this, but you can delete them to show only non-US IMGs. And it will show you the number, or not the number, the percentage of IMGs who are applying to this program. So for example, the University of Alabama Medical Center program, 1% of the people who apply are non-US IMGs. So this percentage shows you or tell you the people who are applying. But if you want to know more about the people in the program, you need to go inside of the program page itself. So this is basically the interface of the program of the University of Alabama. It gives you the link of their website, their address, their email, the program coordinator and program director details, and also it tells you like here for year 1 they accepting or they are providing 26 positions for year 1. Okay. and they are sponsoring J1 visa, which is also important for us as non-US IMGs. And here you can see all of the details about the program. What is the program is offering. For example, this program unfortunately doesn't show if they are offering, for example, moving allowance, free parking. It does not. Oh yeah, sorry. It says here the program offering. This is my profile section, as I told you. If you change these stuff in my profile section, it will show here if it matches or don't. So yeah, the program is actually offering free parking and so on. So yeah, these are the details of the program. It's university-based. The average hours per week is 60 hours and so on. But if you move all the way to down here, you can see the characteristics of the applicants who are getting interviews. So it shows you like here, the people who signaled. So 76% of the people who applied to this program has signaled and were offered an interview slot. People who aligned their geographical preferences according to this program also had 65% of the people had an interview slot. But this also, take it with a grain of salt. It could be true, it couldn't be true, because we still don't know how authentic and how updated, actually I should say, how updated these data are. So yes, these are the things that kind of like important to you, because if you signal this program, you have 76% chance to get an interview, but still you don't know 76% are those IMGs, MDs, DOs. We don't know. So it does not specifically says. But also here, the applicant type, you can see that the non-US IMGs who applied to this program, only 1% of the people, as I said, got an interview slot. But when you move all the way down here, you can see the percentage of the people working and the percentage of residents by medical student types. You can see here that 0% in this program are non-US IMGs, so basically no one. So this is not an IMG-friendly program. So that's how you know if this program is IMG-friendly or not from Residency Explorer. Let's see another program who has IMG, good IMG percentage. So for example, this one, 14% of people who applied had an interview were non-IMGs, non-US IMGs. So when you click on it and you go all the way here, we can see, oh, that's a bummer. Also, 0%. So yeah, it's gonna take a little bit of time, but also, as I said, if you change your profile to match what you are looking for, it will be easier for you to find IMG friendly programs. The thing that I want to say about Residency Explorer that is also better, because we're gonna talk about Freida next. Residency Explorer offer you the opportunity to know the percentage of IMGs working, whether they are US IMGs or non-US IMGs. But Freida here is going to give you only IMGs in general. It does not specifically says the percentages of non-US and US IMGs. So this is only the difference between them. But Freida also offers another good thing that you can use to search. It offers you the map version. So yes, when you come here to Freida, you don't really have to do you don't need to join, or you don't need to have a subscription, or you don't need to make an account, other than on contrast to Residency Explorer. So yes, you can choose what specialty that you are applying to. We're gonna stick to pediatrics for this video. So yes, here it gives you like a general idea about the program and so on. But if you want to view programs, you just click here. Yes, so you can view basically as a list, or you can do a map version. The map version, if the location of the hospital is important to you, this will be easier for you to visualize the location of the program. Only you have to do is choose based on the region or the state. Okay, so if we say, for example, New York, So I don't know what's happening. Yeah. So here in the map, it shows you all of the locations of the programs available in New York City or New York as a state. So you can zoom in, zoom out. You can, yeah, for example, here, if you click on it, you have this program. Yeah, that's basically it. But we're going to stick to the list one for now. Yes, and you can filter the programs according to the location, as I said. And something that is really good about Freida as well, you can change or you can filter according to the application type and the program type. The application type, for example, because you know some programs do not participate in the NRMP or ERAS application. So if you want to apply to those who provide pre-match, you can click here and filter out those who do not participate in ERAS and NRMP. The program type, if you are looking for community-based, if you are looking for university-based programs, also you can filter it out here. Same thing as Residency Explorer, but for me, honestly, I feel like Freida kind of like the interface is much easier to navigate. It's not as busy as Residency Explorer, but both of them are equally important when looking up programs. Also, you can filter based on the percentages of the IMGs. So yes, here you can click on whatever program you're looking for, and you can see all of the details about the program. So yeah, you can see the difference between this website and the other one. This one is much more easier to navigate. It's much easier to look at. You can see here, for example, this program provides 30 positions. Type. Regarding that, I want to say something. When looking up IMG-friendly programs, you need to be sure that you know how to do the math. What I'm trying to say is, for example, if you have a program A and program B, program A, for example, is providing 30, let's say 30 positions, but only 50% of the people work there are non-US IMGs. But program B provide only 10 positions, and 50% of the people work there are non-US IMGs. So your chances in getting an interview in program A is better than program B. So in program B, only 5 people get interviewed or get accepted in that program, but in program B, A, 15 people. So just keep that in mind when you are navigating and reading these numbers, because sometimes it can be complicating, but in reality, it's not. Just having that objective point of view, it can make it easier. Other thing I want to tell you about is what I'm currently doing in filtering out and making this list much easier. I'm using Notion, but you can use Excel sheet. Notion is an application that I'm using to filter my residency programs and making my list. But as I said, you can use an Excel sheet or Google spreadsheet is the same thing. I just find this much more aesthetically pleasing and much more easier to navigate and easier to have that interactive experience. So what I'm doing right now is I am taking all of the programs, because pediatrics is not that much of programs, it's only 219 programs. I'm taking every single program and plotting it into and putting it here into this list. As you can see, I filtered, I put everything that is I am interested in: the city, the state, the region, the institutional setting, the program ID, the website of the program, if it participates in ERAS, NRMP, or it doesn't. If they do have a minimum step 2 score, the number of year 1 positions, the non-US IMGs percentage, which I'm using Residency Explorer to get this percentage. If they provide remote interview, because some programs, or not some, like very minimal number of programs do not provide remote interviews. The number of required recommendation letters, if they have a cutoff of year of graduation, if they do have gap requirement, like if they want US clinical experience, if there is no requirement, if they do require like research or any other medical experience, medical education experience or clinical experience in or outside of the US, if they do provide a J1 visa or not, housing stipend, meal allowance, their links in Freida, Residency Explorer, the program director name and email, program coordinator name and email, and contact person name and email. Then the last thing, I have tiers. The tier is basically this is very subjective to me. So for example, as I said, if I have a program A that provides 30 positions per year and they are accepting much higher number of IMGs, this is for me is tier 1. But also it needs to align to the things that for me I think it's important, and I feel like I have a higher chance into getting an interview. So yes, I know some people say that that applying to university-based programs can be difficult. So for me, tier 1, it's a university-affiliated program that accept as much percentage of IMGs and provide higher positions. That for me is my top program. It's a tier 1 program. Tier 2, for example, if it's a program that doesn't provide that much of positions, but also have like a higher percentage of IMGs, and it's a university based. That's a tier 2. I can apply to that, but also I need to keep in mind that this program is a university based. I can have some difficulties getting an interview. Tier 3, it's a university based that has only like 1% of IMGs working there, and the number of positions is very small. So that's very subjective to you and what you want to work at, or your future career goals, basically. So having that in mind, it can become much easier to navigate. And when you have this list in front of you, it can be easier to filter it out instead of going back to the websites, because you have basically everything here in front of you. Another thing that I want to pay attention to, sometimes the programs can update their criteria regarding IMGs in their official websites. It doesn't, sometimes they don't share it with Freida or Residency Explorer. So you have to go. That's really important. I can't express this enough. It's very, very important to go to the website of the program and look up the criteria they do require for IMGs. Because sometimes they do require, for example, a US clinical experience, even though that program you saw in Residency Explorer have a higher percentage of IMGs and it provides higher positions, but you don't have a US clinical experience. So that for you, it's a no program. You cannot apply to that because, if you do, you're not getting an interview because it's one of the requirements. So just pay attention to these little details. Don't trust 100% Residency Explorer and Freida. Go to the website itself and research the website. That way you can have a better picture, and everything that you see can plot it into your personalized Excel sheet. Or if you're opting to use Notion is really nice. Actually, you can see it's very neat. You can see everything. You can filter it out. We can ask you, Dr. Nader, if we can do like a presentation on how to do your sheet and using Notion. That would be really good. So yeah, we can do that as well. So that's everything for me. If you have any questions, please let me know. And yeah, we are all in the same boat. We're all struggling with this a little bit, but just seeing that everyone in the same boat and we share the same struggle, because it's a struggling experience right now. It's really stressful. It makes it a little bit better. That's everything for me. So yeah, if you have any question, please let me know.
Thank you so much. Thank you, everyone, for great presentation. Any questions for any of the speakers today? I agree with you.
Dr. Nader, I just have something to add, Shroog speaking.
Oh, sure, yes.
Yeah, it's an advice actually for our junior doctors, because usually we work in the hospital and the patient will come with the history of syncope. But if someone actually collapses in front of you while you're in in the shopping area or train station or wherever, you have to follow the basic life support. Check for the response, ask for the help of the patient not responding, and then check for the pulse and breathing. If they have pulse and breathing, that's okay. Just wait for the ambulance to come. If not, just start CPR. Yeah, that's it.
Sounds good.
Thank
And
you.
sometimes if you think about it, if there is a vasovagal reaction and you expect that, maybe you can raise the leg of the patient. That also can help. Thank you. For this last section of the meeting, any updates, any ideas, any projects, questions about the fellowship itself?
Hi, Dr. Nader, Mustafa. I just want to ask about the topic schizophrenia spectrum disorders, because I already told some fellows to prepare it and it's already ready. Do you think we can present it next week or?
Let me check the agenda here.
Okay.
Yeah, we can move the agenda a little bit. If why don't you? Okay, let's see. We can present it in July 26, if that's okay with the group.
Of course, I will inform them. July 26, right?
Yeah, let me add it here. So it's gonna be after the prostate, after the topic number 1. Okay. Okay, so if they want to add their names on that day, that would be great. So I'm gonna share the screen. So July 26, this will be with the gray team. So I put it in addition to the prostate disease. So we'll see if the team did not assign any people for the first topic, then we can ask them to present that day. If there are 2 topics, I have no problem presenting both topics, but we need to make sure that time between the 2 presenters for the 2 topics will be efficient or just to the point, like you don't have to go deep for both topics, if that makes sense. So we need to make sure we finish within the 2 hours. Sometimes we extend, but if the 2 teams or the 2 topic presenters will get together, that might be a good approach. But let me, for now, they will be presenting on July 26. So I added the topic. They can add their name here.
Okay, I will inform them, inshallah.
Okay, thank you so much. Appreciate it.
Thank you, Dr. Mohamed.
Thank you.
So if there is no other further questions regarding the above topics, we cannot thank you enough, Dr. Nader, for giving us this opportunity to connect, learn, and grow. And I hope we can meet in person soon. Inshallah.
Thank you. Thank you for organizing and taking care of all these topics. Thank you all the presenters, and thank you all who attended today. And I'd like to extend my thanks also to those who will watch the recording in the future. Thank you again, and we look forward to seeing you next week, inshallah. Assalamu alaikum. If you have any questions, please reach out. You can email or text me. I'll be happy to get back in touch with you. Thank you. Assalamu alaikum.
Nader, wa alaikum
Thank you, Dr. Nader. Wa alaikum assalam.
Thank you.